Snakebite Management and Complications in Cambodia by Dr. Ing Sun Hak. So Dr. Ing Sun Hak is the medical director, emergency specialist, and anesthesiologist at Kema Hospital. And he is also the member of Cambodian Society of Anesthesiology, Critical Care, and Emergency Medicine. So please welcome Dr. Ing Sun Hak.
Thank you. Good afternoon. Thank you for the opportunity to be able to speak here to share the experience of managing snakebite in my country. So each year, about 5.8 billion people are at risk of snakebite, and despite the number of more than 10,000 people dying of snakebite each year, the number of clinical study has been drastically reduced each year, and in 2017, WHO actually declared it as a negligent tropical disease. In Cambodia, there is about 86 snake species. However, only 17 of them are venomous, and luckily only about 6 species are very common to cause snake bites in the hospital. One of them are Malayan pit viper. One of the extremely dangerous snakes, usually cause a lot of local effects such as edema, bulbar formation, ecchymosis, necrosis, and coagulation problem. This can be found throughout Cambodia, throughout the plantation, oil plantation, rubber, and tea plantation. The green pit viper, or the white-lip pit viper, is one of the primary cause of snakebite in our country. Luckily, it is not fatal. Usually, a patient who was bitten by this type of snakes present with only some local symptom and perhaps coagulation problem. The roselle pit viper is one of the extremely dangerous snake, which usually, beside coagulation problem, it also causes acute kidney injury, hypovolemic shocks, and also rhabdomyolysis, dark brown urines, and those type of situation. The cobra, one of them is the Moracellata cobra. The local effect is usually minimal. However, the significant symptom is the neurotoxicity involving cranial nerve and bulbar nerve, which usually meaning the patient will evolve into a respiratory paralysis. The spitting cobra is the one and only cobra in Cambodia that actually can spit their venom and defensively and actually cause the cornea injury resulting from the venom into the eye of the patient. The Malayan blue crate, which is the very easy to notice, the black and white banded. It's one of the snake that can cause neurotoxicity and usually difficult to reverse even with antivenom. Three other species which also causing snakebite in our country are the banded crate, the yellow-black banded crate, the red hat, and the king cobra. So this is one of the photo where the black and yellow banded crate is found just right next to the patient, to the villager house. Okay. In the literature analysis of the global burden of snakebite, found that in Cambodia in 2010 has the number of snakebite of more than 800 cases per year. Our latest study in 2021 shows that there is twice the amount of cases. However, in the same year, we believe that the number should be higher than 1,400, as in the oil plantation alone, we got the case report of more than 500 snakebite. Not all of them go to the hospital. That's why the record number is still low. It's about 1,400. Because in our country, we doesn't have the venom testing kit. So to identify the cause of the snake bite, the snake that caused the bite, actually patient will bring the dead snake to the hospital, or the physician will do the syndromic approach to diagnose the bite. So the syndromic approach started with usually we do along with the 20-minute whole blood clotting test, which is very easy to do, and it is usually do bedside patient. You only need a clean glass tube and put 2 to 3 millimeter of the patient blood in it, wait for 20 minutes. If it's still not coagulated, then the test is positive, meaning the snake that caused the bite are usually the viper group. So syndrome 1, usually it's involving local envenomment and coagulation problem, bleeding. Taking for example in this child, you see some small necrosis in the hand, swelling of the hand where the bite is taken, and it was caused by the green pit viper, actually from the patient home actually. These also are the children who was bitten by the Malian pit viper, has some local effect. However, the bleeding is much more severe, and also we notice the bulbar formation. So usually the snake that cause it are the Malian pit viper. Syndrome number 2 is usually having the syndrome number 1 involving shocks, hypovolemic shock, acute kidney injury, which usually caused by the roselle pit viper, and the coagulation part, a problem usually occur 1 to 2 hours after the snake bite. Sometimes they involve some neurological symptoms such as bilateral ptosis, external thermoplasia. However, we also noticed the dark brown urine resulting from the myoglobin in the patient urine. So, as you can see in the photo, this gentleman was bitten by the roselle pit viper. The local symptom is much more severe. The yellow arrow is actually the points of the bite mark, and the local symptoms is much more severe. There's bleeding, and even in the patient trunk, there's also bleeding. Patient was in shock, developing an acute kidney injury, and was later receiving an emergency hemodialysis. In the syndrome 3, patient usually presenting with minimal or small local envenoming such as swelling, but the most important symptom that patient usually presents are the paralysis, which usually is somnolent and respiratory failure. This gentleman came into the hospital in a somnolent state and was later intubated because of the respiratory failure, regained his consciousness about 2 days on mechanical ventilation. This same gentleman is actually the expert in the village to actually catch the snake for his living, and turn out that he was admitted in the hospital. Later, he was discharged, and I'm not sure if he's resumed his profession. That's I don't know. Okay. This children was in a somnolent state. As you can see, the mark bite on her leg, it has a very minimal local effect. Also, these children who present with bilateral ptosis. Okay, the syndrome number 4 is actually a bit different than the syndrome number 3. So, patient with no or very minimal local effect. However, the neurological is much more significant, which is usually we think about the crate bite more. As for example, this girl came into the hospital with ptosis and bilateral diplopia, was later developed into a respiratory paralysis because she was bitten by the Malian crate. Here I would like to point out the effects of the tight tourniquet that was applied as a first aid. If you can zoom in a little bit, then you can see the bite mark over her arm too. Okay, so management and recommendation. Usually when dealing with snake bite, the most important question is usually whether to give the antivenom or not. So before we go into that, I would just want to remind that the antivenom would take several hours to work for it to completely to reverse, or perhaps and the second dose after 6 hours. So usually we must deal with the current situation such as hypovolemia, anemia, or acute kidney injury. So this is the current recommendation to give the ASV. So the ASV is given when there is one or more of the following symptoms such as the systemic environment, neurotoxicity, cardiovascular abnormality, acute kidney injury, hemoglobin, myoglobinuria, and some of the local envenoming. Here is an example of the anaphylactic protocol when giving the ASV. So when giving the ASV, the physicians always has to anticipate the anaphylactic reaction. So there is a good study done in 2011 in Sri Lanka, which suggests a low dose of adrenaline by giving 0.25 milligram adrenaline subcutaneous will reduce the severity of the anaphylactic reaction related to ASV significantly by about 43% in the first hour and about 38% in the hours following up until 48 hours from the administration. In the same study, they also suggest that the medicines that we usually do, or the habit of giving corticosteroid or reduce the rate of infusion to about 2 hours or something like that, will not have any effects on the incidence or severity of the antivenom reaction. The availability of the ASV in Cambodia in 2007, as you can see, there's no more than 50 vials available. Currently, in 2009, there was a report of an increase up to 8 times more available vial, because in this referral hospital in Banteay, Mian Chai province, they use more than 400 vials that year in 2019 to treat the venomous snake bite. Our current availability related to ASV that we use is the neuropolyvalent snakebite, a snake antivenom from Red Cross Thai. This is the type of polyvalent ASV that used to cover, to neutralize the cobra, king cobra, and bandit, and crate venom. The other one is the hematopolyvalent anti-snake venom, which usually cover all the 3 viper available in our country. Okay, this is a case illustrate that I would like to share with all of you this afternoon. A 9-year-old boy came into the hospital 2 days after he was bitten by a cobra in his village. So the patient came in febrile, tachycardia, was in a great pain in his forearm. As we have noticed, his forearm is developed into a necrosizing fasciitis, which is one of the rare complications of snakebite that we rarely encounter. The boy was go under an extensive debridement and under meropenem for 10 days before he was discharged. During that time, he received many surgical interventions like groin flap and skin graft, and the boy was discharged healthy. The cause of the bacteria that caused this necrofasciitis was found to be Morganella morgani and Enterococcus faecalis. There's a study of a cross-sectional survey of the oral bacteria in the snake from Hong Kong. So in this study suggests that the bite from the cobra usually resulting in more accidents of bacteria infection rather than those of the pit viper. And as soon as there is a presence of the wound infection, there are suggestions of antibiotics is the amoxicillin, clavulanic acid plus levofloxacin. The last study is related to the complication of the muscle skeletal injury after snake bite. So this study showed that the ulcerated wound is much more common if the snake bite is happened under a year, and if it is more than a year, patients usually suffer from scar contracture. To deal with this type of complication, a surgical debridement was usually the primary intervention that the surgeon usually do to deal with the ulcerated wound, and the contracture release is usually performed to deal with the scar contracture. Currently, our limitation is to collect the accurate data. So the data was not collected in the accurate manner, and there's also limitations of the number of snakes The current snake list was present by WHO a long time ago, and there's no updated, there's no more study about it. The species, some of the species that we usually doesn't really encounter much often, was neglected in our country. And the casualty report is also quite low. However, the problem could be related to a traditional medication treatment or herbal medication that some of our people still have strong belief over them. Currently, we have no report of the impacts of the coronavirus on the availability of the ASV. There is no such thing as a species-specific antivenom developed in our country. Our goal is going to continue to provide ASV and effective treatment free of charge, which usually covered by the government, and continue to update our guideline, continue to improve the clinical management by going from province to province, teaching our emergency physician how to deal with those type of situations, to trying to educate our people to bring a snakebite patient to the health center as soon as possible. And we are hoping to collaborate with a commercial antivenom production in the future. Thank you for your attention, and thank you.
Thank you.